Well, hello and welcome to today's webinar entitled Hereditary Cancer Syndromes, a Multidisciplinary Approach. Today's webinar is presented by the Hereditary Colon Cancer Foundation and sponsored by our friends at Myriad Genetics Laboratories Incorporated. Myriad was kind enough to sponsor this webinar through an unrestricted grant. I am your moderator and host, Travis Bray, a previvor of hereditary colon cancer, specifically familial adenomatous polyposis, as well as the founder and executive director of the Hereditary Colon Cancer Foundation. If you're not already doing so, check us out on social media. You can find us at LinkedIn and YouTube under Hereditary Colon Cancer Foundation, or on Facebook, Twitter, and LinkedIn at HCC Takes Guts. That's also our URL, hcctakesguts.org. And if you haven't done so in a while, take a tour of the website. We are continuing to grow our content and have a tremendous amount of resources and information for both families and patients, as well as medical providers, medical professionals, providers, clinicians, researchers. While you're on there, check out we have 16 hours of educational content for medical professionals, where we really dive deep into the topics, various aspects of Lynch Syndrome and rare polyposis conditions. We actually just finished our 2016 webinar series entitled Recognizing and Treating Rare Polyposis Conditions. So you can find all of that on there, as well as patient guides for families and information about our family days. I am extremely excited for today's webinar. I'm just very eager for Dr. Daniel Luba to be able to share his vision and the work he's doing on the Monterey Peninsula. Dan Luba is the managing partner of Monterey Bay Gastroenterology Consultants Medical Group, the chairman of the board and president of Project DNA, which is a not-for-profit organization that he's founded on the Monterey Bay Peninsula. And I'm sure he'll talk more about it, but you can check out the work that he's doing at theprojectdna.com. He's also one of our newest directors at the Hereditary Colon Cancer Foundation, which the topic that you're going to be hearing about today, Hereditary Cancer Syndromes, a Multidisciplinary Approach, it was really the exact catalyst and what really intrigued Shawnee and I when we first met Dan Luba, because he is doing amazing work and finding his own grassroots way of diagnosing and treating individuals with hereditary colon cancer and hereditary breast and ovarian cancer syndromes in the clinical setting, basically setting up a de facto expert care facility or a high-risk cancer group on the Monterey Bay Peninsula. So with that, look forward to hearing more about the work that he's doing down there.
All righty. Well, listen, I want to thank Travis and Sean for inviting me. One, to be a director, and two, for giving me the opportunity to give this talk. It's really an honor and a privilege. And I want to thank everybody for taking the time out of their day to listen to this. So what I'd like to do is talk about hereditary cancer syndromes, and as it sort of formally likes to be put, a multidisciplinary approach, but as I like to say, really, it takes a village. These are my disclosures. So when I was a second-year medical student in 1982, I was in a pharmacology course, and the professor came in and told us that they had just discovered a new risk factor for coronary artery disease. And that risk factor was cholesterol. Prior to that, no one knew, believe it or not, that cholesterol actually played a role in coronary artery disease. And he actually got up and showed an angiogram of somebody who had significant plaque that was causing narrowing of the coronary arteries. He then showed an after angiogram, which showed basically a reduction in the stenosis after the patient had lowered their cholesterol. And now today, we see that, in 2016, basically cholesterol testing is done pretty much everywhere. You can't really walk into a physician's office and not have your cholesterol checked. And I would venture to say that probably everybody on this call knows what their cholesterol is or has had their cholesterol tested in the past. The first case of HIV was thought to have occurred in 1920 in the Congo. The first cases in the United States occurred in the 1980s. And I was an intern. I was working at the Boston VA at that time when we had our first patient who came in with AIDS. And it happened to be my patient. I took care of him on the floor on the wards the first time he was admitted, and then he became my clinic patient. And for those of you who don't know what it's like to be an intern, we obviously have a very, very high patient load. We're really busy. But once a week, we get to take care of outpatients, and so we spend our afternoon, we see about 6 patients, as well as doing all the rest of the stuff that we have to do as an intern. And so I would see this patient usually every other week, and he would come in typically with some complaint. One time he came in with a headache, and he ended up having cryptococcal meningitis. Another time he came in with shortness of breath, and he ended up having pneumocystis pneumonia. Another time he came in with a foot drop, and I don't think we ever figured out what was going on with him at that time. Obviously, I was an intern. I was new to medicine. I was pretty much in over my head. Typically what I would do is I would ask questions to the head of ID. Unfortunately, his office was located on the 11th floor of the VA. Our clinic was on the first floor. The elevators didn't usually work too well, so I would run up 11 flights of stairs, present this case to him, and we would try to figure out what to do. Needless to say, as we sort of blundered through this and in his care, needless to say, I didn't get out very early on those days for most of the time. Again, fast forward now to 2016, and we have routine testing for HIV among high-risk patients and those presenting with specific infections. And there are HIV clinics in probably almost every county throughout the United States. So BRCA1 was discovered in 1994 by Skolnick. BRCA2 was discovered in 1995. In 1913, Worthen described a pedigree. He called it Family G, who had colon cancer, uterine cancer, and gastric cancer. In 1966, Lynch described 2 large Midwestern families, and he termed them Family N and M. In 1991, the Amsterdam criteria were developed, and in 1993, MLH1 and MSH2 were discovered. So where are we in 2016? Are there any systematic screening programs in the community? Are there any systematic testing programs? Are there any long-term programs to follow and treat affected patients? And I think the answer to these questions are no. So why is that? And I think the common response is that it's because of the prevalence. I mean, these are rare diseases. We hardly ever see them. I hear the word rare used to describe hereditary cancer syndromes all the time. And if you ask a person in the community if they have patients with hereditary cancer syndromes, the vast majority of people say, well, maybe I have one. But if you look at the prevalence of HIV in the United States, it's about 1 in 300 people. I'm a gastroenterologist, so I spent a lot of my training studying Crohn's and ulcerative colitis. And it turns out that the prevalence of Crohn's in Olmsted County, which is where the Mayo Clinic is, this is the highest prevalence in the United States, was found to be 1 in 500. And the prevalence for ulcerative colitis is about 1 in 500, maybe a little bit higher as well. Well, the prevalence for breast and ovarian cancer syndrome is about 1 in 400, and the prevalence for Lynch syndrome is 1 in 400 as well. So I don't think that we can use the prevalence argument as an adequate argument for describing why we haven't developed any models in the community. What about the lethality of HIV? And obviously, this was a dramatic presentation. People were getting infections, and they were dying. But on the other hand, people die of cancer as well. There was also the concern that women could get infected with the virus while they were pregnant and transmit that virus to their child. And obviously, this was something that we just could not tolerate. But again, look at hereditary cancer syndromes. Here, entire families are affected, and this is passed down usually as an autosomal dominant trait. I guess one of the major concerns is the need to protect the privacy of patients and prevent genetic discrimination, because obviously hereditary cancer syndrome, we're talking about the DNA, we're talking about people's blueprint, it's the essence of who we are. And we certainly don't want to have any discrimination against patients because of their genetic makeup. But again, we seem to have managed pretty well with HIV. So several years ago, I decided to set up a genetics program in our office. I practice in a small town, it's Monterey, California. In order to get here, you're usually driving through some pastures. You see cows along the side of the road, there's a lot of farming. And our nearest major academic center is about an hour and a half away at Stanford. So we decided to see whether it was possible to do it. We did a feasibility study to evaluate the implementation and outcomes of a systematic program to assess genetic risk and a counseling process in the community, looking specifically for Lynch syndrome. And I worked side by side with my partner, Jim Visario. The study was sponsored by Myriad Genetics, and we used a PREM model, which was developed by Faye Castrinos and Sapna Singhal. So we knew that Lynch syndrome was the most common hereditary cancer, colorectal cancer syndrome, and that it affected somewhere between 1 in 300 and 1 in 500 people. We knew that many patients with Lynch syndrome were not identified, and that was partly due to the complexity of existing diagnostic criteria and algorithms. We decided to use the PREM model, which was a computerized personal and family history risk assessment tool that provided a quantitative risk estimate for people with Lynch syndrome mutations. And it turns out there were studies that were done that showed that if you scored 5% or higher, it was cost effective to do genetic testing at a cost of $26,000 per quality adjusted life year saved. We also knew that systematic risk assessment, counseling, genetic testing, and management for Lynch syndrome had not been assessed among individuals with and without cancer in a community medical practice before. So what we did was we recruited patients from our office and our ambulatory endoscopy center. They had to be proficient in English in order to take the PREM. The PREM was offered on computer tablets as a self-administered questionnaire. And the providers of the study were 10 docs, all in the community, 1 nurse practitioner, medical assistant, scheduling, and intake personnel. So what we did was when a patient called up to make an appointment, we gave them their appointment and we told them to find out their family history of colon, uterine, and ovarian cancer. We also would send out demographics forms to the patients to find out their insurance coverage, and we sent out a family history questionnaire to all these patients as well. Before a patient's appointment, we would call to confirm their appointment. And again, we told them to find out their family history of colon, uterine, and ovarian cancer in order for us to take better care of them. Patients who scored greater than or equal to 5% on the PREM score after they went into the examining room, watched a 4-minute video on Lynch syndrome. And then we would go in and see them, and we would talk to them about whatever it was they came in for, because obviously no one wants to come in with abdominal pain and start being talked to about their family history. But after we were done talking to them about whatever it was that they were presenting with, we said, you know, kind of concerned about your family history. And for those patients, we offered them, we talked about genetic testing, we counseled them, and the vast majority of the patients told us that they were real concerned about their family history too. It wasn't something that was new to them. In the endoscopy center, we did things a little bit differently. We did the phone calls, we did the questionnaires, we did the PREM score, but we did not think it was appropriate to try and counsel patients and do genetic testing while a patient was waiting to have a procedure. So for those patients, we scheduled them to have a follow-up visit for the counseling and genetic testing. Patients who received genetic testing completed a survey about the process, and providers completed a survey at the end of the process as well, and we reported this on a 5-point Likert scale. consenting patients submitted their buccal mucosa or blood samples. The specimens were analyzed by Myriad Genetics, and we used DNA sequencing and/or large rearrangement analysis using a panel that included MLH1, MSH2, MSH6, PMS2, EpCAM, and we also looked at MUT-YH. So we broke the study down into two parts. The first part was an initiation phase or a beta phase. Basically, we were just trying to figure out how to implement this in our office. And that went for about 2 months, and during that time we tested 28 patients, and there were 3 positive mutations. We then did the formal study phase, which lasted 6 months, and during that time there were about 5,400 patients, and 98% of them were offered PREM screening. Of these, about 60% were eligible and agreed to complete the PREM. 177 of the 3,000 patients, or about 5.6%, scored greater than or equal to 5%. And of these, 145, or about 82%, pursued genetic testing, and we found 3 positive mutations. So during the entire study duration of 8 months, there were 173 patients tested. 6, or 3.5%, were positive for Lynch mutations. And here you can see that we found positives in MLH1, MSH2. We found 3 positive in MSH6 and 1 PMS2. We looked at why there were more MSH6 positive when we would typically think of MLH1 and MSH2 as being the one that we would find more frequently. This may have been a sample size problem, but probably more likely it had to do with our patient population, because a lot of our patients are older. They're in their 60s and 70s. A lot of them are unaffected. So we probably preferentially found less penetrant genes. We also found 23 variants as well, and 4 monoallelic MYHs. So we then did surveys, and I think the surveys were actually very important. The patient survey showed that about 84% thought that the survey, the questions that we sent prior to the appointment, prepared them to answer questions regarding their personal and family history. 84% believed that the information they provided was complete. 98.6% of the patients felt that they understood the information provided on genetic testing, and 95% of the patients felt that they had enough time to discuss their questions regarding hereditary cancer syndromes and genetic testing. We also surveyed the doctors, and all the doctors reported that the patients provided enough family history information to complete the colon cancer risk assessment. They all thought that the PREM model was an adequate tool for identifying patients appropriate for genetic testing. 91% of the patients felt that, 91% of the providers felt that they had enough time to answer the patient's questions regarding hereditary cancer syndromes and genetic testing. And all the providers said that they would continue using this process to screen and test for patients at risk for hereditary cancer syndromes. So our conclusions were that it was feasible to incorporate a risk-based screening program for Lynch using the PREM model to direct genetic counseling and testing in a community GI practice, and that systematic risk assessment for both affected and unaffected individuals led to identification of patients with inherited susceptibility to cancer, and provided the opportunity for appropriate screening, surveillance, prophylactic surgery for patients and their family members. I'd like to now present a couple of cases. So the first case is a 54-year-old white female who was referred to see me because she had reflux esophagitis and dysphagia. Now remember, I'm a gastroenterologist. She never had a colonoscopy. She'd never had an upper endoscopy before. Her past medical history was significant for mixed connective tissue disease, most consistent with scleroderma. Those people who typically have motility problems in their esophagus, hence the evaluation for dysphagia, which is difficulty swallowing. Past surgical history was significant for breast implants, which was subsequently removed when she developed a mixed connective tissue disease because she was concerned that the implants may have somehow affected or caused her mixed connective tissue disease. So if we looked at her family history, her mother had breast cancer at age 42 and then developed colon cancer at age 62. Her mother's twin sister had breast cancer at age 65. Her maternal aunt had breast cancer at age 70. Her brother died of melanoma at age 44, and her sister had breast cancer at age 59. On her father's side, her uncle had pancreatic cancer, and her grandmother had pancreatic cancer as well. So we did genetic testing, and she turned out she was BRCA2 positive. So her breast cancer risk was somewhere between 43 and 84%. Her ovarian cancer risk was somewhere between 16 and 27%. Pancreatic cancer risk, a little unclear if it was due to a family history, about 7% risk. General population risk was about 1%. And the melanoma risk is elevated. General population risk is somewhere about 1.6%. So the patient decided that she wanted to have a bilateral mastectomy. She was concerned about implants because of her mixed connective tissue disease, but reconstruction can now be done without implants or without silicone implants. She was postmenopausal and wanted to have her ovaries and fallopian tubes removed. As far as her pancreas and risk for pancreatic cancer went, I thought that the BRCA2 probably came from the maternal side. The pancreatic cancer was on the paternal side. We talked for a while and we decided to do a baseline MRCP. I'm not sure that we'll do an EUS. And we did a colonoscopy, and there were 6 cephalus-serrated adenomas, and she'll need a follow-up colonoscopy in 3 years. So for all of you listening to this, you may say, like, okay, so why did I present this case? I mean, this is a case of a typical BRCA2 patient. There's nothing all that unusual about it. There's nothing extraordinary about this. What is extraordinary is that this patient had a primary care doctor. She had a rheumatologist. She had routine mammograms done, and she was being seen at a breast center. She had breast implants done, which meant that she was seen by a plastic surgeon who was obviously did a lot of breast reconstructive work. And not one person during this entire time picked up on her family history and did genetic testing. It took her going to a gastroenterologist for a dysphagia evaluation to be worked up for this family history. And I think that probably most people would agree that this family history is pretty much strong enough to be like hitting somebody over the head with a sledgehammer. And that is not, I'm not indicting the physicians in my community, because I think actually we have a fairly progressive community. I give talks all over the country, and this is pretty much where things are throughout the country. So let me present a second case, and this is a 67-year-old female. I've been following her since 1994. I continue to see her today. She's one of my favorite patients. Between 1994 and 2014, she had 8 large adenomas that were removed. Most of them were right-sided. Most of them were big enough that I had to take them out piecemeal, so I had done lots of colonoscopies during this time. In 2013, she complained of some heartburn, and I did an upper endoscopy, and she had a 1.5 centimeter duodenal adenoma. I don't typically see those. We did another upper endoscopy a year later, and she had 3 duodenal adenomas. One of them was flat and measured about 1 centimeter in size. During this time, she's actually a golf pro. She developed some pain in her shoulders, so she had an MRI, and they found a 2 centimeter lung nodule, which turned out to be an adenocarcinoma in situ, which was resected. Her family history is significant. Her maternal half-sister had colon cancer at age 50. Her maternal grandfather had colon cancer at age 55. Her maternal grandmother had breast cancer at age 49. A maternal aunt, first one, had breast cancer at age 48. Another maternal aunt had breast cancer at age 50. A maternal cousin had a leiomyosarcoma at age 60. And a maternal cousin, another one, had prostate cancer at age 50. And her father had lung cancer at age 68. So with the duodenal adenomas, the polyps, the history of colon cancer, I was certainly concerned about a polyposis syndrome. Obviously, she had significant breast cancer, and I talked to her about genetic testing. And she said, oh, you know, don't worry about genetic testing. I've got that taken care of because I'm being followed at a high-risk breast center, and they're planning on testing me for breast and ovarian cancer syndrome next month. Well, this was around the time that we were doing the study, so panel testing hadn't come out yet. And I looked at her and I said, you know, I am really concerned about you having genetic testing for breast and ovarian cancer syndrome, because to the best of my knowledge, you usually don't get duodenal adenomas with breast and ovarian cancer syndrome. And you usually don't have that strong a family history of breast cancer with a polyposis syndrome. So I really had no idea what was going on with this patient. But I had access to panel testing because I was part of, I was doing a study with Myriad, and so we did panel testing on this patient. And she ended up having a TP53 mutation, which is highly unusual in somebody who's 67 years old. And to be honest, as a gastroenterologist, I had no idea what a TP53 mutation was, and so I went to the books, I looked it up, and I found out that they're at high risk for getting sarcomas. I looked up the NCCN guidelines, and essentially they told us that we should be doing total body MRIs. So we did a total body MRI, and she had a 4-centimeter liposarcoma that was resected for cure. She's 71 years old today. I continue to see her. She's doing fine. And we continue to find polyps on colonoscopies and remove them. And as I said, she's a real, she's now survived 2 cancers. She had the lung cancer that was resected for cure and the liposarcoma. And I can tell you that we never would have found that liposarcoma if we hadn't have done the total body MRI. And we wouldn't have done that if we hadn't done a panel test and found the TP53 mutation. So it was because of patients like these and patients with Lynch syndrome, when I started trying to look to people, I realized I couldn't take care of these patients myself. I could certainly take care of a Lynch patient's GI problems, but when it came to managing their uterine and ovarian cancer risk, I couldn't do that myself. I went to look for gynecologists who were interested in Lynch syndrome, and really I had no real circle, no real group of physicians that I could go to that would help me manage them. So I decided to start Project DNA, which was a nonprofit corporation, and our mission was to create programs that would systematically identify, screen, and enable physicians to take responsibility for and care of patients with hereditary cancer syndromes. So if you look at breast and ovarian cancer syndrome, the prevalence is about 1 in 400. Lynch syndrome, the prevalence is about 1 in 400. Breast and ovarian cancer syndrome, autosomal dominant inheritance. The lifetime risk of breast cancer is between 40 and 85%. The lifetime risk of ovarian cancer is between 16 and 60%. Lynch syndrome, autosomal dominant inheritance. Lifetime risk of colon cancer is up to 80%. Lifetime risk of uterine cancer is up to 70%. Lifetime risk of ovarian cancer is up to 12%. Do these sound somewhat similar? Well, of course they do. And why is that? Because they're both, I think, due to DNA gene mutation, DNA repair gene mutations. In Lynch syndrome, it's a mismatch repair gene mutation, so basically a spell check gene. In breast and ovarian cancer syndrome, it's a mutation in a gene that repairs fragmented DNA. So it makes sense that both of them present somewhat similarly, and it also, to make things sort of easier, if you understand Lynch syndrome, it's not very difficult to understand breast and ovarian cancer syndrome, and vice versa. So, hereditary cancer syndromes, there is a lack of systematic programs to identify patients. There's inadequate education of healthcare professionals about these syndromes. There's a lack of systematic programs to ensure appropriate screening of patients with these syndromes, and there are a paucity of physicians who take responsibility for and care of patients with hereditary cancer syndromes. So our goals were to create programs in the community that would facilitate identification of patients who are at risk, screening for patients who are at high risk and only those patients at high risk, and giving physicians the tools so that they could take responsibility for and care of patients with hereditary cancer syndromes. We targeted various specialties, including gastroenterologists, breast centers, gynecologists, primary care, oncologists, oncologic surgeons, and pathologists. I talked to you about what we did with our practice. We were able to successfully implement electronic capture of all new patients' family history. We used, at the time, computer-generated risk for Lynch syndrome. We also now use questionnaires more frequently. We did genetic testing of patients with high risk of Lynch syndrome. We were able to effectively counsel and implement appropriate screening tests. We went to our pathology department, and we implemented universal testing of all colon cancers for Lynch syndrome using immunohistochemistry, but it quickly became apparent to us that that made no sense whatsoever. Because you could have a surgeon who would come out and say something like this. He would see a patient and say, I've got good news and I've got bad news for you. The good news is that we resected your tumor and you're cured. There was nothing, no residual tumor left. But the bad news is that it looks like you may have something called Lynch syndrome, and because it puts you at such high risk for developing a second cancer, it's about 30% within 10 years and 50% within 15 years, we really should have done a different operation. We should have taken out the vast majority of your colon as opposed to just doing a segmental resection. And if it happened to have been a woman, and the woman was done with past childbearing age, and at the, perhaps around 40 or 50, they should have taken out the uterus and ovaries as well. Or you could have even had a worse situation where this was a rectal cancer that was removed and they had preoperative chemotherapy and radiation therapy, where a significant number of those patients have no residual cancer found, so there will be no opportunity to do immunohistochemistry. So what we did was we switched to now test by immunohistochemistry all cancers at the time that the diagnosis was made on colonoscopy. So when we do a colonoscopy, we see a colon cancer, we take biopsies of it, we send that for immunohistochemistry. At the same time that we're referring the patient to the surgeon, to the oncologist, the radiation oncologist, getting CT scans and blood tests, etc. So it becomes part of our staging workup so that we can do the appropriate surgery at the initial time. We then looked at ovarian cancer and we noted that only about 25% of patients with ovarian cancer have genetic testing. And so we said to the pathologist, why don't you put a comment on your report for all the patients with ovarian cancer of epithelial origin to say, consider genetic testing for breast and ovarian cancer syndrome as per NCCN guidelines. And they basically said, okay. It was about a 5-minute phone call. We then went to Salinas Valley Memorial Hospital, which is the other hospital in our community, and they had already implemented universal testing of all colon cancers using immunohistochemistry, and we talked to them about doing it on the colonoscopy biopsy specimen, and again, they agreed within a 5-minute phone call. We also talked to them about putting a comment section on their report for the on ovarian cancers, and they agreed to do that as well. We went to our breast center in Monterey, and they are now in the process of implementing systematic screening of all patients at risk for hereditary cancer syndromes, looking for breast and ovarian cancer syndrome as well as for Lynch. We went to the mammography center in Salinas, has already successfully implemented screening and testing for all patients at risk for hereditary cancer syndromes. Pacific Cancer Care is in the process and is well along the way of implementing, again, a systematic screening program for all patients at risk for hereditary cancers. Peninsula Primary Care is a multi-specialty group that's employed by Community Hospital. There's 35 providers in 4 locations, and they are also in the process of implementing a systematic process to identify all patients that they see. Clínica de Salud is a system of 9 federally qualified community health centers in Salinas Valley. They have committed to implementing a systematic hereditary cancer program, and we're hoping to start doing that sometime early next year. Pinnacle Healthcare takes care of the agricultural workers and their families in Salinas. There are 8 locations in Salinas Valley. In the wintertime, when the agricultural industry moves to Yuma, Arizona, they also go down and have a clinic down there in Yuma so they can continue taking care of them. They have also committed to implementing a systematic hereditary cancer screening program. We're hoping to do that as well early next year. Salinas Valley Healthcare System has 70 employed physicians, primary care, OBGYN, surgery, oncology, infectious disease, pulmonary, and they have a mammography center. They have fully allied with Project DNA, and they are identifying a champion in each of these areas and having them ensure that screening programs are set up. They have already, they have identified 4 people who they are trying to, they're going to send to City of Hope. One is enrolled in the City of Hope course. That's the nurse navigator for the mammography center, and they want to send 3 others hopefully next year. We support our physicians in the community with bi-monthly case conferences. The 2 cases that I presented were cases that we presented at our case conferences. We usually present and discuss between 5 and 8 newly diagnosed patients, and we usually have between 20 and 25 attendees at each conference. So our vision was to create a joint community hospital and Salinas Valley Memorial Hospital program. That's now a reality. They jointly funded our website. We have a social media campaign, and we're doing a community education program. Monterey County is a founding chapter of Project DNA, and we hope that it will expand throughout the country. We've implemented systematic screening programs for hereditary cancer risk at breast centers, primary care practices, gynecology practices, oncology offices, and our GI practice, as well as others. And we're actually putting this poster up. It's now in our hospital, in our oncology offices, at our breast centers, and our cancer center. And we try to really emphasize that, you know, while we can't change your family history, we can change your family's future. So I'd like to thank you for your attention. If anybody has any questions, I'd be happy to answer them.
Wow, thank you, Dan. Every time I talk to you about this stuff, I get the jitters because I just see this big problem that I'm really happy that there's different ways of coming at it. You know, when we first started the organization, in my head, I was like, all right, I'm going to get everyone to Carol Burke or Joel Samater. And then as I've run this organization over the last 4 years, I realized, like, you know, sometimes that's just not accessible. And, you know, there's so many patients, so few specialists. And even if there are specialists, I was surprised when I was living in Park City to find that people in Salt Lake Valley couldn't go see Joel at Huntsman because it was out of their network. Or it just wasn't accessible to them. And then I realized, okay, the problem's a lot bigger. And I love these different approaches to solving the problem. So, you know, on one side you have like Iceland, who can genetically screen everyone on the whole island and then know everyone on the whole island that has Lynch Syndrome. Kind of hard when you have 300 million people. So I'm really, you know, I've been excited since day one, the way that you kind of, what I call, constructed a de facto high-risk cancer clinic on the peninsula for the people there. Dennis Onan has a question. Dennis says, thank you for he asked you to thank him. He asked me to thank you for him, with community pronouns in that sentence, for the presentation, and that you may address this later, but he'd like to know if you've been able to incorporate a genetic counselor into this program, and if in addition to the family history collection, if you have incorporated MSI testing rather than IHC testing on the biopsies of colorectal cancers.
Right. So as far as the genetic counselor, you know, the nearest genetic counselor that we have is about an hour and a half away at Stanford. Most of our patients have not been going up there, but they're certainly welcome to do that. We tried to use I like to term it a 1-800 genetic counselor. Our hospital paid for that at one point, and about 2 people actually utilize that during a year. And so I think what we've been trying to do is really train the physicians and train nurse navigators in the breast centers to identify people. And with our hereditary cancer case conferences, that has really been incredibly helpful, because the people who are going to that, we're getting gastroenterologists, we're getting oncologists, we're getting gynecologists, radiologists, pathologists, all together sitting around. We've got plastic surgeons there sitting around a table discussing cases. And it's really incredible, because most of the specialists really have a fairly good understanding of what to do in their specialty, how they would approach, let's say, a breast reconstruction if somebody doesn't want to use implants, other things, so we actually do have a lot of information. And we do have at our case conferences a genetic counselor. We bring a genetic counselor down to our case conferences, and they usually come and can answer questions as well. Unfortunately, with the current payment model, genetic counselors don't really, it's difficult to get funding for them and get reimbursement. So we have not been that successful in doing that. We do have genetic counselors come to our case conferences, and we can refer them out to Stanford, which is where the nearest one is. As far as MSI, I think it would be a little bit difficult to do MSI on the colon cancer biopsy specimen, because you need normal tissue as well as biopsy tissue specimens, so you'd have to get biopsies of normal tissue as well as not just the colon cancer. And we've been pretty much sticking with the immunohistochemistry, but if there are compelling reasons, we could certainly look at adding things. The other thing is that MSI needs to be done more at a specialty kind of lab, whereas immunohistochemistry is pretty simple to send out to commercial lab.
Thank you. We have several questions on this, and it looks like we have a bit of time. Before I jump into those, I have a question that I'd like to ask. What were the challenges, or maybe it was easier than I think, to go through the Monterey Peninsula and identify the pathologist or the radiologist or the nurse navigator, the people who had an interest in the genetic cancers and wanted to work with you on this project? What was it like trying to permeate through the different clinics and the hospitals to find these people, to bring them together for the conference? I think people will be interested in that.
Oh, it was hard. I've been here for 25 years now, so I know a lot of people, and essentially I just started asking people and talking about it. I bothered people a lot. People would turn around and walk the other way when they started seeing me sometimes. But it was sort of funny. There was interest. I think in general most physicians are pretty easily realize that they're not doing a very good job of identifying people with hereditary cancer syndrome. Getting them to change their practice patterns is a little bit more difficult, but over time they were able to do that. And I think it was really fascinating, because our chief medical officer, who's an infectious disease physician at Salinas Valley, he had been supportive, but sort of lukewarm supportive of the program the entire time. And we had a conversation one time recently, and during that conversation, he asked me whether insurance was covering the testing, and I told him that it was. He asked me if our Medi-Cal, which is basically Medicaid, so California it's called Medi-Cal, whether they were covering the testing, and I told him that indeed they were in our area. And then he said, and you're willing to see these patients? And I said, yeah. And he said, so you're telling me that you're willing to counsel someone about getting a mastectomy? And I responded to him that, of course not. I told him that, I would see them, I would make the diagnosis of breast and ovarian cancer syndrome, and then we would talk about their options, and then I would send them to a specialist, to either their gynecologist or a breast surgeon, to talk to them about mastectomy. And he told me later that was it. That was what did it for him, because it was basically the decentralization of the process that he saw as being most significant. He was an infectious disease doctor, and he would get phone calls. You know, people would do Lyme testing, and they would get these results, and they would have no idea what the results meant, and they would call him all the time about what the results meant. And he would say, like, you know, if you don't know how to interpret the results, why are you ordering the test? And the decentralization of this process, basically bringing everybody up to the level that they could actually do the basics and then refer out if they had questions, that was what sort of made him a lukewarm a supporter to someone who is now totally on board.
Awesome. Thank you. I actually wrote that down, the decentralization of the process, and I think that's probably why I get the jitters when I think about it. You know, every time I talk to you, or Sean and I are putting together some information, I keep thinking about there's 1 in 400 people with Lynch syndrome. 80%. We were just talking to James Church. 80% of people with Lynch syndrome are diagnosed with cancer at the time of their Lynch syndrome diagnosis. So, you know, when you ask, where are these people with Lynch syndrome? Well, they're hiding behind rocks or under a pile of leaves, apparently, because and they're only coming out once cancer strikes. And trying to get these issues solved is just a monumental task. But, you know, as with anything that causes you anxiety, decentralizing it alleviates a lot of that stress, and it makes it a little bit more palatable if you have a support team. So that's cool. Jamie Jessen asked, did you get any pushback at all for IHC testing by your pathologist? And then she followed that up with, while many do see the value, their budget can limit them, and that seems to be an issue.
No, not at either of our institutions. That was not, I mean, that's standard of care. The only issue may turn out to be with Medicare, and they are covering it, but they may not cover it. There's some question as to whether they are going to be enthusiastic about covering it in people over age 70. But we found people who are over age 70 with cancer that have Lynch. So the answer is no. We really haven't had any issues, and not at our hospitals. They're willing to do that. And I think that there's good reason for it, because, you know, if you find a Lynch syndrome patient, it's cost effective to do this stuff. You know, because it costs way more money to treat a patient with cancer than it does to find out that they have cancer and prevent it. I'm sorry, find out that they are at risk for developing cancer and prevent it.
Betsy Dotson asked, when you say implement a quote-unquote systematic approach to screening, I know you're able to do this for your study with Myriad, but have you been able to continue that in your busy GI practice? If so, how? And then she has a couple of follow-up questions that I'll hold off. Well, actually, she asked, what process do you recommend? Unfortunately, their EMR has not been able to be modified to capture this information effectively.
Yeah. Well, I think that, so the answer is yes. We have continued to do that. I think that the phone call, we continue to do the phone call where we say, you know, you have an appointment on the 6th, and please find out your family history of colon, uterine, ovarian, and breast cancer. We obviously add breast cancer because even though we're GI practice, it will pick up the second, you know, the two big hereditary cancer syndromes. So yes, we do that, and I think that's easy. Sending out a family history questionnaire, I think that can be done anywhere. You know, along with most places do send out information to collect patients' demographics before they come in. Priming them really helps when you make that follow-up phone call to remind them of their appointment, asking them about their family history of colon, uterine, ovarian, and breast cancer. Again, very easy to do. We use questionnaires now more than the Prem. As I've gotten better, I can usually pick out people. I think when I was first starting, I really didn't know when to pull the trigger, and that was the big thing. Having that 5%, that yes or no answer for me, really was helpful in getting me accustomed to pulling the trigger and saying, this person I should test. Now I find that, you know, I look at the family history, I can pretty much tell who to test and who not to test, and so I use it for sort of equivocal cases, you know, people who are very old and may not have as strong a risk. But, you know, I think that getting certain things done in a lean way is incredibly important. I think, one of my goals is to try and get these things implemented in the major EMRs, and I'm hoping that can be something that I can do in the near future.
I think one of the things you said, I meant to mention this earlier, you feel more confident now, you can see the family histories now, and I would assume that that's probably in part because you completed the City of Hope Cancer Genetics Genomics course. And I don't think you actually said the whole name out, so I want to make sure everyone knows about Dr. Weitzel and the City of Hope's team, the Cancer Genetics and Genomics course. And maybe if you want to kind of really mention quickly why you took it and how that's helped in the implementation of your Project DNA program.
Well, I'm a community doc. I'm not at a university, and I learned a lot on my own, but his program was outstanding, and I think it gave me a lot more knowledge, a lot more information. It also established a place that I could, people that I could call, that I could ask for questions, networking, etc. I don't want anybody to walk away from this saying that I don't think that the university setting is important, that genetic counselors are not important. I call people with questions all the time. But I view it the same way as I take everything else that I do. I take care of most patients with inflammatory bowel disease, but every once in a while I just get stuck and I refer them out to a university setting. And this is sort of the same thing. So if anybody is interested in taking the City of Hope course, I highly endorse it.
All right. Well, wonderful. Thank you. Amy Stoddard says, /asks, you mentioned that the PREM model is the primary source that's identifying patients. However, there are limitations to the PREM model, and it can miss patients who meet other NCCN criteria for Lynch Syndrome. I'm not sure what LSGT is. Has this been considered?
Yeah, as I said now, we did that for our study. And I think that was really important, and I think that was really helpful to get us to pull the trigger. I don't use it nearly as much now. I don't find it's that necessary. I find that, the family, looking at the family history is usually enough for me to know when to test and when not to. And obviously it's not going to, detect people at risk for breast and ovarian cancer syndrome. And I think even as a gastroenterologist, most of the patients I send for testing are for breast and ovarian cancer syndrome and not for Lynch. And my practice now encompasses people, who've been, positive for BRCA1 and BRCA2, positive for ATM, CHEK2, PALB2, Lynch, MYH. It sort of goes through the whole gamut. And working with the other specialists in our community, we seem to be able to take care of them. So no, I don't rely on computer testing solely. I use it occasionally when I need it now.
Well, let's get to Corey Jasperson's question. What are you doing for patients with abnormal tumor results but no germline Lynch syndrome mutation? AKA, and I think after being a CGA, Heather said we're not supposed to say this, but AKA Lynch-like.
Well, you still have some patients who have very high risk, and so we treat them based on their family history. So it's not like I'm testing people and saying that if you test negative, then you have nothing. Obviously you have a family history, and we go by the family history. If somebody is very, the thing about GI is that most of the time those patients, they have lots of polyps, so we don't even have to just say 5 years. If we're taking out polyps and they're big polyps, we're going to bring them back more frequently. But if somebody tests negative, I treat them I base my treatment based on their family history and use guidelines for that.
Avery Miller asks, I am a GC and am underutilized where I work and feel like I have a lot to give. How can GCs be more involved in this process? Where I work, there is a great need for physician education, but very low uptake, even on how to stratify risk for patients prior to genetic counseling. How can I use Project DNA in my practice?
I understand her sentiments. I think that it is a problem with the model, and that's why I set up Project DNA, because I think that, the whole point is that, if you walk into a doctor's office, you cannot be put back into the room without having your blood pressure checked. It just does not happen. And if you were to say to physicians, we're not going to check your people's blood pressure anymore, and the medical assistants are not going to be doing that anymore, it's the doctor's responsibility just to check the blood pressure, I would venture to say that very few people would have their blood pressure checked, especially if they're coming in with, belly pain or reflux or something like that. They're not going to check their blood pressure. And the reason for that is that there's not a systematic program. There's not a leanly, using lean techniques and guidelines. We haven't set up systematic programs to check, to evaluate whether people are at risk. And I think that's what needs to happen. And I think it needs to be, physicians need to look at this as this is their responsibility, because if there are thousands of physicians throughout the community, hundreds of thousands, and there's, 500, 600, 700 genetic counselors, there just aren't enough. And, if we abrogate our responsibility and don't take responsibility for identifying these patients, then the really question is if not you, then who? Who is going to do this? And the answer is right now, no one is doing it. So we have to change. We have to make physicians responsible, and that's what Project DNA is all about. And it's hard, but we have to create a change in the mindset, and we have to make physicians feel that they're responsible for this, just like they're responsible for hypertension, just like they're responsible for hyperlipidemia, just like they're responsible for AIDS, just like they're going to be responsible for Zika if somebody gets an infection. We have to learn, and we have to update our knowledge base in order to take care of these patients.
It's Avery. First of all, she had a follow-up statement. So Jamie Jensen said, very inspiring. Avery follow-up has said, it's so great to see a physician taking charge of this problem in such a proactive way. Avery, I'm sure you have my email address. Reach out to me. I'd be happy to connect you and Dan if you have any further questions. Robin Palmer says, Dr. Robin Palmer, asks, do you consider the Amsterdam criteria? If so, do you include ovarian cancer as the Lynch Syndrome cancer?
Ovarian cancer, ovarian cancer, I was going to use the word, ovarian cancer is a Lynch syndrome cancer. Ovarian cancer is a breast and ovarian cancer syndrome. If you have ovarian cancer, you qualify for genetic testing. And to be honest, it's easier to use the ovarian cancer to justify genetic testing for breast and ovarian cancer syndrome than it is to use it to justify Lynch syndrome. But, for people like me, the panels really make it easier because we don't need to sort of say, I don't need to know which syndrome they have. And I'll throw back to people that I don't quite understand how somebody can look at a pedigree and determine whether or not a person is going to have PALB2 or BRCA1. And so the panels really make it a lot easier for us, and we don't have to be quite as smart as we used to be. And I would contend that I don't think we were ever quite smart enough to figure it out without this stuff. So yeah, I use ovarian cancer as a Lynch cancer. Ovarian cancer is useful for testing, so is uterine cancer. I ask about breast, the four questions that I particularly look for, or the four cancers, is colon, uterine, ovarian, and breast cancer.
Awesome. And follow up from Avery. So there's no there. She says there isn't a role for a genetic counselor. I'm not against changing the models, but would like to be involved in some way.
No, there is clearly a role. I mean, I have genetic counselors on my speed dial. Don't get me wrong. It's like saying that that I'm a gastroenterologist. It's like saying, so there's no role for a gastroenterologist treating diarrhea. Of course there is, but I don't treat every case of diarrhea that comes in. Most of the cases are treated by the primary care physician. It's when it doesn't go away. It's when it's more complicated that I get involved with it. I hope I did not want to come off as thinking that I'm an expert on hereditary cancer syndrome, because I'm not. I would venture to say that probably most people on this call know more about hereditary cancer syndromes than I do. What I'm trying to say, though, is that the model that we have set up is not working because the vast majority of the people are not diagnosed. If you look at our county, in Monterey County, there are about 500,000 people. We should have about 2,500 people with either breast and ovarian cancer syndrome or Lynch syndrome, and I can tell you that we have not identified even a small fraction of them. But since I've been doing this, I now have a fairly large group of patients with hereditary cancer syndromes that I'm finding. So I think this is working. But obviously, when we have questions, I think that the role for genetic counselors, when they're available, is really probably not to decide who needs to get tested, but to interpret the test and to counsel the patients. Unfortunately, as I said, we just don't really have that many here locally.
So Avery did say, it's probably a longer discussion. She agrees with you on the point. And it is a discussion. It's a discussion I'm glad that we've started, that we're having, that the issues that the community is facing with the diagnosis, screening, and treatment are huge. They're varied, and it's going to require, in my tool bag, not only do I have a hammer and a screwdriver and a pair of pliers, I actually have a few different types of pliers and a few different types of screwdrivers. So, there's so many different ways we're going to come at this, and I'm honored that the organization could be a part of the discussion. I'm happy that we had in excess of 200 people register. I'm thrilled at the conversation that came on. I'm honored that you came on our board, that you're sharing your insights with us, that you gave your day to this presentation. And Dan, maybe you could tell how can people get in touch with you if they have more questions?
So if people have more questions, they can. My email is dluba@montereygi.com.
dluba@montereygi.com. All right. Well, thank you, everyone. Thank you, Dan. I'll touch base with you offline, and hope everyone has a wonderful day, a wonderful Veterans Day, and a wonderful weekend.
Thank you so much.
Thank you. Bye-bye.